Good afternoon, everybody. I'm Visha Vinchiha. I'm relatively recently appointed head of respiratory at NHLI, and it is my enormous honour and privilege to be able to introduce Professor Pallav Shah's inaugural lecture this evening. First of all, I'd like to welcome our special guests. Thank you very much for coming. I'd like to welcome all the staff from the Royal Brompton. I'd like to welcome all the staff from NHLI, and I'd like to particularly welcome Pallav's family and friends this afternoon. What I have to do first, of course, is tell you to silence your mobile phones. I always forget, and I've been told that I'll be shot if I don't give you the emergency fire briefing, and I'll read it. In the event of an alarm, you leave the building, turn left into Kell Street, turn left again into Guthrie Street. You'll need a Google app, but if you haven't got your Google map, then follow me. So, Pallav originally qualified from Guy's Hospital, and he came in 1992, I think that is correct, as an SHO here to the Royal Brompton Hospital. He then performed research under Margaret Hodgson's supervision, who I'm delighted to see here today. He then he carried on as a senior registrar, both at the Shah in Westminster and at the Royal Brompton. And in 1999, he was appointed to a substantive consultant physician post between the two hospitals. And I think it's very important when you hear all about his work today, is that he's a very busy clinician. And Pallav's main interests have been in interventional bronchoscopy. And originally he worked in lung cancer, and he'll show us that he extended this into airways disease. And there's very much more to come in the future. He is an innovator. His innovation is of direct benefit to the NHS. So this is why his work is so important and has been so successful. Despite being an innovator and being very busy, he's really gone out to tell everybody about the work and to teach the next generation. He's an educator not only in the UK, but also an international. He is a fantastic role model for the future generation. And my word, we do need more young doctors to enter respiratory medicine. This is really important for the future. He's been a great role model both for the Brompton and NHLI, and really typifies why it is so important to align clinical medicine with your academic partner. In addition, he has recently been awarded the prestigious Royal College of Physicians of Edinburgh Gold Medal. And I should say, on a personal note, whenever I ask Pallav to do anything, he's always very keen. The best thing is, if you really want to do a good COPD course, you always ask Pallav to go along, because you know at the end your assessment score will be very much better. Dr. Ascalzi, who's here in the audience from Chile, met both of us yesterday. He said, "Professor Shah, I love coming to your lectures, but I can never get in." Well, we do have a full house today, ladies and gentlemen. We're in for a treat. Can I now hand you over to Professor Pallav Shah to deliver his inaugural lecture on journey towards bronchoscopic surgery. Pallav.
Thank you very much, Visha. I'm really going to find it a struggle to live up to that introduction now. And, you know, I'm really humbled to see this Paul Wood Lecture Theatre absolutely brimming. And I'd like to welcome our special guest, Baroness Boothroyd, who's one of our patrons of the hospital. Thank you for coming this evening.
Anything for you, Pallav.
And basically, I want to welcome all of you. I mean, I think I may be here getting all the accolade, but actually, I think most of the people in this room have contributed towards this journey towards bronchoscopic surgery. And I'm hopefully going to take you through this and hopefully also give credit to these wonderful people who are part of it. So actually, this journey started when Professor Geddes handed over his lung cancer clinic to me. And quite often we'd see the situation where a patient would have a tumor completely blocking off the main bronchi or the trachea. And at that time, we either had the choice of Mike Henk, 10 gray, 1 fraction radiotherapy, or Peter Goldsrod to do a rigid bronchoscopy and a mechanical debulking. Now, Peter was clearly the single surgeon here. He was too busy doing curative procedures, so we had to think a bit laterally. So we started actually using colonoscopy snares. So that's a colonoscopy snare and colonoscopy probes. And on the left there is Tom Soteja, who is one of my colleagues from the Vrije University in Amsterdam. So we basically started using colonoscopy snares in the airway. And I'll give you a brief example. This is a 67-year-old lady. She's actually one of David Cunningham's old patients who had a colorectal cancer, undergone surgery and chemotherapy, and was getting more and more short of breath. And this is the X-ray. And you'll see that the left lung is completely collapsed, the trachea is deviated to the left side, the diaphragm's up, and this is what I saw at bronchoscopy. So basically, we use these colonoscopy snares to lasso over the tumor and basically pull it out. This is one of the few occasions when an Indian is allowed to be a cowboy. So you can see in one swoop, we managed to clear the trachea, save the trachea, and the next step really was to try and free up the tumor from the edges of the bronchi. And once we free up a little bit more of the tumor, I can then go back in with the snare and basically loop a little bit more of the tumor and sequentially take it out. And this lady was quite sick. She had about 2 milligrams of midazolam. I didn't have the luxury of an anesthetic colleague in those days, but with a kind of calm, safe approach, we can usually resect this kind of tumor right down to its base. And you'll see again, I'll go back with the lasso, really try and loop the snare over the tumor, and each time just pull it out of the airway. And towards the end of it, we should be able to get right down to the bottom of the airways, which you can see it right up there. So this was the result. And you can see the trachea is already in the midline, diaphragms come down. Clearly, we haven't cured this patient. This is a palliation. But this patient did quite well, actually died about 18 months later with brain metastases. So you can see that this is a really good tool for palliation. Now, some of you, or most of you, should be familiar with the cool wall. So I'm going to take the privilege today to create my own cool wall. Now, unlike this cool wall, you know, Jeremy Clarkson, a.k.a. Mike Polkey, Richard Hammond, not me, but I have the choice of choosing my own cool wall for bronchoscopy. So there's no doubt where this goes. This goes into the hot area. And like I said, Tom Soteja was very helpful in helping me. I'm not sure we can call the moustache hot anymore, though. And the other culprits who helped me were Severe Singh, Richard Lewis from Worcester. And together, over the next few years, we went on to make this kind of standard of treatment. And now Olympus actually make pulmonary snares. So we don't have to steal from the gastroenterologist anymore. The other approach, which is probably a simpler approach, is to freeze. And we can use laughing gas or carbon dioxide. And if you allow it to vaporize, it actually cools the tip right down to about minus 90 degrees centigrade. And we can use this technique to also try and remove tumors. Here's another example. This is actually a patient with breast cancer. And she was getting more and more symptomatic, cough, breathless, and this is her bronchoscopy. So again, when we look down with the camera, she's got a tumor completely occluding the right main bronchus. So on this occasion, what we can do is, this needs a little bit less skill than the cowboy technique. So we just take the probe and basically you oppose the probe onto the tumor itself. It freezes the tumor, and that freezing effect allows the tumor to stick to the probe, and then you just pull. And you pull off a piece. And let it thaw, and then go back. And basically, this is real time, this actual procedure, and you can see basically freeze, pull, and out. And you're already seeing the airway open up. And one more should probably do the job. It does bleed a little bit, but not too much, because the freezing effect also freezes the blood vessels in the tumor. So you get some blood loss, but not the kind of torrential blood loss that you might expect. So here's another bit of the tumor being pulled out. And then when you go back in, you'll see that that airway is now completely clear again. So where should we put that? Well, this one's a bit obvious, isn't it? It should be sub-zero because it's minus 90 degrees. And one of the key people who drove this forward was Jürgen Hetzel. He comes from Ulm, the birthplace of Einstein. And basically, he's driven this technology forward, probably to a greater extent. And nowadays, we do the same technique for transbronchial lung biopsy for interstitial lung disease. In the old days, my friend Simon Jordan and Michael Dusmet and Eric would be doing open lung biopsies, but nowadays we've kind of only used them sparingly and perform the same procedure for transbronchial lung biopsies for interstitial lung disease. Sometimes we have to support rather than just ablate, and this is a kind of challenging example of this. This is a patient who had lung cancer. Actually had been resected by Peter Goldstra about 9 years ago, and then he's getting more and more short of breath. And you can see his left lung's completely gone, because that's the pneumonectomy. The right lung looks okay, but the eagle-eyed radiologist in this audience will notice that the right main bronchus is actually a pinhole. So when we looked into his airway, he did have only a pinhole. So you can see the left side's been cut open and it's blocked, and the right side is just a pinhole. So in this situation, we can use, what we've done is actually taken femoral vascular balloons with razor blades on it, and we use these vascular balloons to basically pop open that tumor, cutting it open, and then we place a stent to try and maintain it open. So here's a stent going into that area, and you can see the basal segments of the lower lobe there, and once we're in a comfortable position, we basically deploy this stent very slowly and gradually, and here's the stent in the airway. So again, we haven't cured this patient. We've basically palliated him by opening up his airway and stenting it. And this patient actually lived for another 9 months before dying from respiratory failure. So I think that's a cool technique. We'll leave it there. We'll leave it there. Now here is a patient with moderate smoker, smoked about 40 cigarettes for about 40 years, had a cough, breathlessness, and in this patient with the scan we can see that they've got a tumor at the top of the right lung. You can see in all the different sections. But when we did a PET scan, what we could see is that there was a gland next to the trachea which was active. So basically, if we sample the tumor at the top, we still need to know what this gland is doing. So the better way of managing this patient is to sample that gland. And traditionally, we did that with rigid bronchoscopy by the surgeon, and I'll go through that in a minute. But what we did was we used this new technology, which is endobronchial ultrasound, and basically allows a needle to come out to the ultrasound. And here you can see a lymph node, and we can sample lymph nodes as small as 4 millimeters in size, and you'll see a needle coming in through there. There's the needle coming in. This is the superior vena cava, a big blood vessel underneath it, and basically we can sample this gland, even if it's above 4 millimeters in size, get samples which usually our pathologists are able to give us an answer on, and these days even get molecular typing on it. And here's just a steady version to show you. This is basically the view we get at the bronchoscopy. This is the ultrasound image, and basically put the needle out, and here you can see the needle in the gland when you're sampling it. So the pathologist can't say you've missed, you've got evidence where you've hit it. So this is the gold standard. So this is what used to keep Mr. Dusmet, who loves doing mediastinoscopies, busy. You basically make a cut over the breastbone. You then put this big metal cylinder through there, and then take some biopsies. Well, the alternative is no general anesthetic, no cuts. We can basically use an endoscope, look at the lymph nodes adjacent to the airway, put a needle into them and get some samples. Another advantage is that even our brilliant surgeons can only sample the tracheal areas and the subcarinal areas, whereas I can get to these green lymph nodes and these pink lymph nodes. And if I put the endoscope into the gullet, I can even get to these lymph nodes. So basically, we can reach further in a more non-invasive manner. And actually, this technology has just gone ballistic. I spoke to my colleagues from Olympus, Tokyo, a few weeks ago, and they said to me they have just sold 1.6 million needles. So if we use that as a surrogate measure of this technology has only been around for approximately 10 years now, and there have been over 2 million procedures worldwide. But to get there was a challenge. This is Hikaru, who invented the endoscopic ultrasound. But this endoscopic ultrasound is a bit of a giant. You really can't get it into the trachea. So we had to go and meet him. We had to pass some dubious exercises, which usually involved eating some rather dubious-looking food. And if you actually managed to pass that exercise, then he would make this superb ultrasound scope for us. And Mark Krasnick, who is one of my Dutch surgical colleagues, who's looking a little bit cold rather than cool, actually was the first person outside Japan to use this technology, and then Felix Herth and Jarl Canham, who's in the audience, managed to get hold of it. And I think this is so successful that you could put this technology absolutely anywhere in the cool wall, but I think it's super cool, just because of its success. Unless Mike's going to make me change. Now I'm going to turn to emphysema. So emphysema, you can see that in this lung that's taken from a patient with emphysema, how destroyed that lung is. And despite the fact that we use millions and millions of inhalers, they're really not going to do much in this situation because this lung's very destroyed. This is the normal situation. So we use our diaphragm as a bellow to pull in air in and out of the lungs. We have the alveoli where the gas exchange occurs. But in the emphysema situation, the lung is damaged, hyperexpanded. You can see the diaphragm's hardly moving. So the exchange of gas is a lot slower. Also, the alveoli are destroyed, so the surface area for the gas exchange is also much lower. So this is the situation we're dealing with, and it kind of shows you why inhalers aren't going to solve the problem. Here are two lungs. The difference is only one's an inspiration and one's an expiration. Yet, you're really tough to see a difference between the two. But if you can create a couple of artificial airways, this is what happens. The lung completely deflates down. And that's really what we then develop. So basically, we do a bronchoscopy. We use ultrasound Doppler to look for blood vessels. And my advice is if you find them, it's better to avoid them. We then find areas which don't have any blood vessels, put a needle through it, and then put a balloon through it to dilate it. And once we've done that, we recheck again with ultrasound, and then go back and place a stent in that hole. So here's the stent being placed. Now this procedure is actually an interventional bronchoscopy dream procedure because you're going to do all of these things, not just once, but 6 times. And it's quite a dramatic technique. It gives you instant result. And I'll share that with you with this example. So this is a 62-year-old gentleman. He smoked for England, I think, 50-pack years. And you can see that this is the residual volume, which is a measure of how overinflated his lung is. And his lung is 300% of what it should be. So 3 times its natural volume. And this is a real procedure. So basically, we put a needle in through the airway. The needle is actually going into the lung tissue itself. We then use the balloon to enlarge the size of that airway that we're creating. And effectively, you create an airway about the same size as the adjacent segments. So the adjacent segments are about 4 millimeters in size, 5 millimeters in size, and you're creating an airway about the same size. Once we've created that airway, we then go back with the stent, and here's the stent going through, and the first bit of it is just the balloon and the delivery catheter. The white section is the stent. Once we've got the stent in the right position, we basically expand the balloon and deliver the stent into situ. And in fact, if you really look carefully, you can't probably see on this projector, but when you look through that balloon, what you're looking at is the emphysematous lung actually in situ in the patient. So we've basically created an airway, which is the same size as segmental airways, and we therefore term this procedure airway bypass. And this is what happens in just 24 hours. So this patient's lung function has doubled. It went from 21% to 42%. the amount of air trapping, so remember they were at 3 times, and you can see it's dramatically dropped to about 1.87. So I don't think I've seen any other treatment that does that in 24 hours, completely changes the life of these patients. In fact, one of the patients came in a wheelchair and then walked up a flight of stairs to get his x-ray done the following day. So completely unbelievable. So we actually did a randomized, double-blind, sham-controlled study, and it showed that we had dramatic effects at day 1, but unfortunately, by 3 months, the effect had worn off. And that's basically because the stents that we created would seal up. So, nevertheless, it was a very, very important study. It's the first time as bronchoscopists and pulmonologists and interventionalists that we did a proper scientific randomized double-blind controlled study. Before that, it was all about, yeah, I've done a few, you can all do one now. So this was quite groundbreaking. And when I tried to explain this to my Italian surgical colleagues, they thought this was what I meant by a double-blind randomized controlled study. And then there's my bronchoscopy friends, obviously. So they can see no evil, or hear no evil, or say no evil. But I'm going to tell you all the truth. So this is what sometimes happens when I bronchoscope these patients and create a hole. We get a flood of blood. And then we're there trying to rescue these patients, sucking away. And I've sped up this video, so about half an hour later, you're still there. You don't need to go to the gym after this procedure. You get such a good tachycardia and workout. Gym sessions are unnecessary. But by being calm, having a great team, which some of you are there already, you can rescue this situation and save the patient. But it needs a lot of training trying to stay calm in this kind of stressful environment. So this is how I do my training. So if you pass this test, then you can do this procedure. So I think that procedure is very cool. And Joel Cooper, who Duncan get his nose, and Peter Macklem, who's probably the doyen of physiology, were the key people who developed this procedure. And Dirk Jan Slebers, who's up here. This was the first time we actually met. We were rivals at that stage. A young DJ there helping us push this forward. The other approach is actually to use one-way valves. So in this situation, what you can do is you use your bronchoscope to deliver valves into the lung which allow air to escape from that lobe but not to go back in. And by doing this, you can allow the lung to deflate. In fact, Professor Geddes, who's in the audience, and Mike Polke were the first ones to push with this technology. And here's an example of this 66-year-old gentleman. He had a lot of breathlessness, 60 Pacquias, even better than the last case. And this was his CT scan. And you can see that on the left side, there's a lot of black, damaged lung. In addition, there's this white area there of what we call collapsed lung. So what we did was we put valves in to the top of the left lung and the lingula. And here's a video of the procedure. So basically, we take a delivery catheter. I partly deploy the valve, wedge it against the sort of airway segment, and then very slowly release this valve. And you'll see the next valve going in. So again, the same kind of technology. You basically partly release the valve. You then block off that airway. Once it's in the right position, we then deliver the valve. And you'll see it opening up, releasing the air. But when they breathe in, it closes up and therefore doesn't let air back in. So effectively, you can then cause collapse of that lobe. And here's the CT scan afterwards. So basically, you can see the amount of black lung there is completely reduced. So you've lost the volume in the damaged area, and the more collapsed lung has re-expanded. Now, just in case, you can see really quite a dramatic response again in this patient. And I'm not just showing you my best cases, because we've tested this quite thoroughly. We've done a randomized double-blind controlled study, which Nick Hopkinson led, and that again shows that FEV1 improves by about 20%. These patients were walking more than 30 meters after the procedure. The Stelvio study, which Karen Klusters, who was also around in the front, performed, she managed to beat the patients into walking 74 meters more after the treatment than before. And then Sam Kemp led the last study, and again you can see improvements in the walk distance of about 79 meters. Their quality of life scores improved by about 8 points. What does 8 points mean? So it's really the difference between a patient being housebound to being able to go to the shops, buy their pint of milk, buy their newspaper, the difference between them becoming dependent or independent, being able to wash, dress, cook their own meals. So quite dramatic results, but what we've shown is that in several randomized controlled studies that we made a difference. And again, this journey's been long. We started with this back in 2002, and it's taken 15, 16 years to get here, but we've now got nice approval to treat these patients. We're very soon going to get FDA approval. This technology is already widely used in Europe, and the results are far greater than what we can achieve with inhalers. In addition, I'm just showing you the same data in a different way. So if you look at the responders, clinically meaningful responders, and you'll see that if you treat the right patients, about 60 to 80% of patients get a clinically meaningful improvement in either their quality of life or their lung function or how much they can do. So that definitely goes to the cool spot as well. But this technology actually has taken a lot of people's work. So you can see all the characters who have really helped push this forward. Duncan Geddes, Mike Polke, Dirk-Jan Slebos, Karen, Sam Kemp, Justin Garner, Will McNulty, Nick, and Zaid Zumot, and Felix Hirth up there. And that's a really young picture of Sam. This is when he was my research fellow. He was brimming with... he was very keen then. What else can we do? So you've seen two different approaches. One is to create holes. One was to deflate the lung. Well, this is the third approach we can employ. So this is a 54-year-old florist. She's an ex-smoker. She stopped smoking 10 years ago, and again was becoming more short of breath. She was actually on maximal medical treatment, and the biggest thing that upset her was she wasn't really able to go on holiday anymore. The last holiday she had was about 5 years ago. And this is her lung function. Again, she has a lot of air trapping. Her flow capacity is very limited. This is the scan, and I've just shown the scan by enhancing all the damaged areas of lung. And again, a little bit like that first video I showed you, you'll be challenged to spot the normal lung in that area. So what we've done is we've put these nitinol coils into these patients. So Felix Hirth was actually the first person to do it in the world, and then Dirk-Jan and me started following up. And basically what you do is you put a guide wire into the lung under X-ray control. We then put a catheter over that. We then take the guide wire out, and once the catheter is there in situ, we then insert a coil, which is that pre-shaped coil that you can see. It goes in straight, but then as you remove the catheter, it starts taking up that shape that you saw earlier. So here's the catheter coming back, and then when you deploy and leave that there, it opens up and releases the coil. And the coil, being made out of nitinol, takes up its original shape. And basically we put about 10 to 15 of these in each lung. And this is the patient, and you can see again you're getting improvements in their lung capacity, reductions in the amount of air trapping that they had, and this was the chest X-ray in this patient after the procedure. Now, about 3 months after we did this procedure, she did manage to escape from Heathrow Airport without setting off any alarms and managed to get to South Africa, which is where she wanted to go. So, again, we've gone on and studied this technology in more detail. We've done randomized controlled studies again. So basically, since that airway bypass study, this has become embedded into our practice. We don't just do single open label studies. We try and get the highest level of evidence to really make sure this technology or whatever technology you're developing works for these patients. Not only have we collectively developed these treatments, we've also collectively changed how we do the science. So here, again, you can see quality of life measures of reductions of -7.4. Now, the best inhaler studies, and we've got some of the gods of COPD in this room, and they will tell you that the best inhaler studies will give you a drop of -3.7 with SGRQ. And yet, these treatments that I've shown you today on average give you 8 points. Here you can see the patients were walking more by 52 meters, and lung function's been improved by about 12%. So once again, that was one study, randomized control, which showed you improvement. We then went on to do a number of studies. There was a European study, there was a French study, and then there was a multi-center study including 315 patients, which was conducted in several centers in the US and Europe. And once again, what we see is quite significant and sustained benefits up to 1 year with these patients. Admittedly, in this last study, the results don't seem as good as our previous results, but we have to thank our American colleagues for that. They managed to drag down our results significantly. And when we compared Durkheim and my results and some of the European centers, we have double the amount of improvement that they do. So you have to be careful when you do the large studies. So I think that should also go into the cool one. And this is the cool group that helped me develop it. There's Sam, Zaid Zumok, Will McNulty, Justin Garner hiding up here. And this was at Chelsea and Westminster. And in fact, I should ask my Chelsea and Westminster colleagues to help me bring back our flying fish. The last way of trying to destroy the lung in emphysema is just to cook it. And this is like a little bit of chicken being cooked. Basically, you can see the airway, and you can see it going white and blanching right in front of your eyes. So it's like meat being cooked. And basically, what we do is we take a CT scan, we work out the volume and the tissue content, and we then work out the amount of calorific energy we need to give. We do a bronchoscopy, put a balloon catheter up into that segment, and then essentially heat it up and cook that bit of tissue. And here below you can see what happens. So basically, that area that you've treated fibroses down. I've exaggerated here. You can see that area of the lung in maroon, and you can see how over 3 months it shrinks right down to a smaller size. And once again, we did a randomized controlled study, and again have shown that you're getting improvements in lung function with this technology of around 10 to 15% at 6 months. Once again, you can see that SGRQ, our quality of life score, again is over 8, so minus 9.7. And again, patients are walking by about 30 meters more than before the treatment. Remember, all of these patients we've treated are already on the best medical treatment that we can offer. So they're all on all the right inhalers, they've had their flu vaccine, they've all done pulmonary rehabilitation. So this is really what we can achieve above and beyond that therapy. The other advantage of vapor treatment is that you can target different bits of the lungs. So if you have a lobe, with the valves you have to collapse the whole lobe. With the coils you're treating the whole lobe. But with this vapor technology, we can just target the very, very small area of the segment that you want to ablate and leave the rest untouched, if at all possible. So it's pretty obvious where that goes. I think that goes into the hot section. So next I'm just going to touch on asthma. So we're going to move away from emphysema and touch on asthma. So asthma, as we all know, is basically because the muscle in the airways contracts. And when it contracts, it closes off your airways, and therefore the patient feels breathless and wheezes. So if we can reduce the amount of smooth muscle in that airway, we can reduce the amount it's going to constrict, and therefore we should reduce their symptoms and improve their quality of life. And this is how we do it. We use a radio frequency generator, we use a catheter, and it's got a wire basket, and you can see there's an uninsulated portion in this catheter, and that's where the energy is delivered. So we basically open up the basket in the airways as far down as we can go. It releases thermal energy into that area, heating up the tissue to around 65 degrees. So that temperature, the airway mucosa is untouched, maybe a little bit of blanching, but not much. But we cook the muscle, and the muscle just is destroyed and never comes back. And we've now got patients 10 years on who still have benefit. So that's really the procedure. It's a very slow procedure because you have to treat every little small airway right up to the proximal airway. And this morning we did one procedure. We did 120 activations. Each activation takes 10 seconds, and then you have to deal with the mucus. So it's not a short procedure. So I try and put them all on Sam Kemp's list whenever possible. So one of the big problems with asthma is that we've got so many patients, particularly at this hospital, who are on steroids. They're having high-dose oral steroids. This completely destroys their bones, causes cataracts, high blood pressure, diabetes. So anything we can do to reduce the steroids is crucial. And basically what we showed in one of the randomized control trials is that if you try and systematically reduce the steroids, in the control arm, we were only able to reduce it by about 25%, but in the treatment arm, by about 63%. So a 50% greater reduction in steroids following treatment. So that in itself, I think, is a worthwhile finding with this therapy. But we did 3 more randomized controlled trials, all in increasing severity of disease. One of the parameters I'm going to show you is the quality of life score. And for this technology, if you have an improvement of 0.5 points, it's clinically meaningful. And you can see that compared to control, that there was a clinically meaningful improvement. But also, the sicker the patients, the greater the benefit. So again, these are patients who are coming into hospital very regularly, on a lot of steroids, and this particular therapy helps improve their quality of life. But what's even more important, it reduces the amount of exacerbations. We had one patient who used to be in A&E at Chelsea and Westminster almost literally every 2 to 3 weeks. And we treated her with bronchial thermoplasty about 3 years ago, and now she only comes to clinic once a year. So it completely changed her lifestyle. We can reduce the amount of hospital visits, we can reduce the amount of emergency room visits, and we can reduce the amount of hospitalization. Now I'm showing you the data here at the end of 12 months, but we've now got patients who we've treated 10 years ago, and basically this benefit seems to be sustained. So it's not a one-off effect, it's a single treatment, but the benefits are sustained. Now, this is the time where I usually argue with my asthma colleagues, because they love giving drugs like mepolizumab and omalizumab, which costs £10,000 a month, and the patient has to come every 2 to 3 weeks to have an injection into hospital. But yet we could do this therapy, which would reduce their symptoms, and it's a one-off therapy at a fixed cost with no recurrent cost. So that definitely goes into the super hot, no, I think hot section. Super hot, if my asthma colleagues would take it up. So now I'm going to turn to COPD. So we've gone through lung cancer, emphysema, asthma, and now COPD. And COPD is a big challenge because it's quite a mishmash of conditions. The patients get a lot of mucus production. They get that smooth muscle spasm as well, like asthmatics. The airways are very irregular, and they have an increased cholinergic tone, and I'll come to that in a minute. So basically, this is how most of the drugs we use are targeted. So our vagus nerve transmits a signal, releases acetylcholine, and some of the inhalers we use in COPD really try and counteract that. So the Spiriva is trying to counteract that effect. So rather than giving the Spiriva, which doesn't go everywhere evenly, what else can we do? Well, we can just burn the nerves. So if we burn the nerves, we reduce the amount of acetylcholine being released up there, and therefore reduce the amount of muscle spasm, reduce the amount of inflammation, reduce the amount of mucus production. And this is how the procedure is done. And basically, once again, guess what? You bronchoscope the patients. You then put a catheter in, which is a super-cooled catheter, so it allows the mucosa to be protected and really transmits the energy, so it hits the nerves. So the electrode is in a 90-degree crescent, so basically you treat all 360 degrees off the right main bronchus, and in the same procedure, you then treat all 60 degrees of the contralateral airway and try and kill off the nerve. Now, Marty Mays, he was an engineer and then a doctor. He developed this procedure, and with Durkheim, Arshang Vapour, myself, we've been trying to do this procedure, and we've now completed 2 clinical studies and 2 randomized controlled studies. And this is what it looks like. So this is the pre-treatment. This is what it looks like during the procedure. Just after the procedure, there's a little bit of blanching where you've just heated up that airway. And then when you come back three months later, there's no scarring, no constriction, no narrowing. So this is a very, very innovative way of trying to do this. Now, these are some of the results very early off the sort of data. So this is what the baseline results are. So you give them an inhaler, and this is what Spiriva does. So tiotropium or Spiriva, one of the biggest selling drugs, improves their lung function by about 75 mils. If you just do the treatment alone, no inhaler, you can see we're improving their lung function by about 100 mils. And these results are up to 1 year, so they're not 2 months, 3 months, up to 1 year later. Now, something even more interesting. So you treat them, and then give them the inhaler, and you can see you're getting benefits of about 150 mils. So you almost double the effect. So you get a summative effect. You treat them, you ablate their nerve, and then give them the inhaler, and you get an add-on benefit. And this probably happens because you relax the airways, and then the drug can actually get much further down into the airways. So I think that definitely deserves to be in the super hot section. And I think it's going to be a very revolutionary therapy. We've done 2 randomized controlled studies. We're about to also trial this in asthma as well, to see if we can have the same beneficial effect in asthma. And my anesthetic colleague John Thornton dreads it when I come up with these stories, because he's got to now anesthetize this very sick asthmatic and rescue them after the procedure. Chronic bronchitis. Well, chronic bronchitis is really difficult to treat. We don't really have a single treatment. We don't have a drug treatment. We don't have any treatment for chronic bronchitis. And chronic bronchitis is basically production of lots of mucus with some inflammation in the airways. But we were using liquid nitrogen to treat the cancer patients. And one of the cancer patients that was treated also had COPD, surprise, surprise, because they smoke. And what we saw is, this is the untreated size, and you can see the typical COPD chronic bronchitis phenotype, smooth muscle hypertrophy, lots of inflammation, lots of blood vessels, and lots of goblet cells that make mucus. But in the side that was treated with the liquid nitrogen, you can see less smooth muscle, less goblet cells, less inflammation, but still the basement membrane is still completely intact. So this has the potential of being a therapy for chronic bronchitis. And this is what we do. So basically, we take liquid nitrogen and push it down the airways and create Christmas. So here's the frost being formed. So that cools that airway down to minus 296 degrees. But also you have to remember that liquid nitrogen expands to 7,000 times its volume. So you have to be very careful with it. Otherwise you're going to cause pneumothoraces, pneumomediastinums, basically blow up the patient. So you have to be very, very careful with it. And this is what it looks like. So immediately before the treatment and immediately after the treatment, you cannot tell what's happened. It looks the same. There is just no effect on the mucosa. But what you've done is you've killed off the mucosa, and it regenerates from the stem cells within 2 days. And here's another example of the treatment. So basically this is a little bit like bronchial thermoplasty. We go as far as we can. We treat one bit of the airway. We then move about 10 millimeters more proximal, treat the next area, and so forth. And roughly we do about the whole lung, we probably need about 70 to 90 such treatments. We've treated 38 patients between Groningen and the Brompton and Chelsea and Westminster so far. I'm going to show you the early data for the first 12. And basically what we're seeing is reductions in the quality of life scores by about 6 points, And most of this effect is by reduction of mucus production. And we have a measure called a CAT score, and this also measures mucus production. And again, if you look at that, we reduce the CAT score by about 3 points, which is quite a remarkable achievement. So basically, that has to go in supercool. It's minus 296 degrees. So I hope I've managed to take you through the journey from normal bronchoscopy through to bronchoscopic surgery, from cancer, emphysema, asthma, COPD to chronic bronchitis. But what's really, really important is that I once again introduce you to and thank the team. So basically, this is the whole team. We started with just Sam Kemp on his own, but it's multiplied. So this is the whole team that's absolutely crucial. And you've got all our fellows, all our important international collaborators, and then all our NHLI collaborators and Imperial collaborators. You've got Nick Hopkinson, Professor Yang, Professor Chung, Omar Osmani, Professor Vishika, and Masa Takata from Chelsea and Westminster. And together, we think that we managed to try and make some changes collectively. So although I've taken a lot of the credit, it's not me, it is a definite team effort. And also, I'd like to thank my family, because without them, I wouldn't be able to really be here and do this either. Thank you very much.
Pallav, it gives me enormous pleasure to say how much we appreciated your talk. I think your work exemplifies everything that is great about your own personal work and what a great environment that we live in. So you started out as an exceptional clinician, you became an exceptional operator, you made observations from your own clinical practice by being an excellent clinician, and what is transformative is that you have now moved these to the international stage, become a world leader, have developed very high quality scientific data to support what you're doing, and what you have done has influenced guidelines in this country and internationally. It's brought enormous credit to you, to both our partner institutions, and it's really a testament to how much you're appreciated by how many people are here, from how many departments in the hospital that you've touched, and from how many different hospitals. And it's really hard to know where to stop with your achievements. I personally ran out of fingers. I do have one tip for any young people in the audience, though, which I think shows how you've managed to survive here, which is obviously by swimming with sharks. And so I commend that to any younger people here. Seriously, though, behind every great clinician and every great team is a leader, and you are that leader. And I think there is much more. I think there is much more to come. Behind every great leader, of course, is a great family, and it's wonderful to see Marla and your children in the audience. And I think, especially your children, will hold this memory and realise what a talented father they had. So you must be very proud about that. I also see some of your patients, so some of them survived clearly. Now, I spoke to some colleagues about giving this talk, and they said the most important thing is not to stand in the way of the audience and their wine. So traditionally, we don't take any questions, but I think if anyone wants to ask Pallav anything, he'll be at the bar afterwards. And I'd like to once more formally offer the thanks of everyone here for such a wonderful talk.
Thank you. Thank you very much. Like I said, I'm really, really humbled to see everyone here today. And really, it is not just me, it is a team effort. And without a great team, you can't do this. Because remember, you're only as strong as your weakest link. So what this says to me is that the Brompton, Chelsea, Westminster, Imperial are a very, very strong link. And I hope you can come and join me for drinks at the top.
Yeah.